Hello, how are you? This is IgX for Minds, and today we are talking about platelets and thrombocytopenia. So, just to check over something about physiology, let's remember that megakaryocyte is the precursor cell of platelets because this megakaryocyte releases around 1000 to 3000 platelets per each one. Also, let's remember that there is a very important hormone to remember that is thrombopoietin. This hormone is synthesized in the liver, and that's why it's very important to consider in those patients with chronic liver diseases some pathologies related to thrombocytopenia, that is, the decrease in the number of platelets when we do a blood count, for example. Also, let's remember that synthesis of platelets is increased with inflammation by some acute inflammation markers like interleukin 6. Also, let's remember that one third of the platelets reside inside the spleen, and the other two thirds are inside the or inside the blood vessels. Likewise, let's remember we have some clotting factors like von Willebrand factor. This is a multimeric protein that is present both in the plasma and also in the subendothelial vessel wall. That's very important because when there is endothelial damage or an endothelial injury, this factor or this protein interacts with another factors of the platelet and clotting factors in order to initiate the coagulation cascade. Likewise, let's remember that endothelium is a system of blood cells that is very important because they they have some antithrombotic proteins in their surface. For example, we have protein C, protein S, antithrombin 3 that they help us to limit the the formation of the clot in the specific injured area. Now, if we watch to the platelet, it has many cellular signaling, for which is very important to remember just some of them. For example, we have here the some hormones or molecules that are related to platelet inhibition. That means they avoid the formation of clots. For example, prostaglandin I2, or also called prostacyclin. Also, we have to nitric oxide. They both will have a function of inhibit coagulation. Likewise, we have another, for example, the initiation of platelet activation, as we have already mentioned, to von Willebrand factor, collagen, laminin, that is the interaction of the subendothelial molecules with the clotting factors or the platelets, mainly receptors that are located in their surface. Also, we have some agonists of molecules that will be part of this coagulation cascade. For example, we have ADP, we have thromboxane 2, which are produced through, for example, thromboxane A2 is produced inside the platelet to the COTS pathway, and that's why aspirin, this drug usually is very selective for COTS1, which is the enzyme that platelet has, and that's why aspirin is very effective when we are talking about anticoagulation for platelets, for platelet aggregation. Of course, we have another signaling pathways, but that's not very important right now. Also, we have some inhibitory properties of endothelial cells we uh, had been already mentioning. For example, nitric oxide, prostacyclin, antithrombin 3, protein C, and protein S, just to mention. But what we have to what we are going to know today is more related to the pathology, and that is some alterations that can present when you ask for a blood count cell, and you see in the results that your patient has thrombocytopenia, and you, of course, you have to see two things: the cause, the consequence, and sometimes the possible treatment that the patient will require. In this case, when we talk about thrombocytopenia, the first thing you have to do is rule out pseudo thrombocytopenia. That is because it has been seen that when the blood sample is added to ETA, this compound to ETA, there are some antibodies that start to agglutinate, and that's why the platelet count will decrease, which will be a false result. That's why it's very important to determine the platelet count from from tubes with sodium citrate or from tubes with heparin. Okay. Now, thrombocytopenia has three main mechanisms. First is the decreased bone marrow production, like can happens in bone marrow sequestration, bone marrow infiltration by malignant cells. The other one is sequestration, like in the spring, and the other is platelet destruction, like can be by some microangiopathies inside the blood vessel. Now, once we have ruled out that our thrombocytopenia is real, is not altered, is not a pseudo thrombocytopenia, we have to do first, for example, we can go to this to make a blood smear to see the blood cells morphology. Because why is it important? Because if I see fragmented red blood cells like schistocytes, we are going to focus our diagnosis to microangiopathic hemolytic anemias of something related to those angiopathies. But if the blood smears show us a red blood cell morphology that it's normal, so we have to think another causes. They can be drug-induced thrombocytopenia, infection-induced, idiopathic, or congenital. Now, let's start for this when our blood smears show us a normal red blood cell. So in this case, when we talk, for example, we have some drug-dependent antibodies that react with the specific platelet surface antigens, and that's why we result in thrombocytopenia. Just when the the drug is present, but if we stop the administration of the drug, so the the pathology or the thrombocytopenia will resolve by itself. We have also what we call immune thrombocytopenic purpura. Well, this is more common in children, because this is a virtually this is an acute disease that appears after an infection or vaccination, commonly by viral eye agents, and it can appear, for example, into 1 or 2 weeks after the infection by a viral agent. In adults, it also can be present, but this is more a chronic disease, and it also can be secondary to systemic lupus erythematosus, HIV, or hepatitis virus C. And the clinical presentation of this will be mucocutaneous bleeding, that is gastrointestinal bleeding, heavy menstrual bleeding, and of course a low platelet count. In this case, when we suspect of this pathology, we have to test for to rule out HIV, to rule out SLA, and also to see the IG levels. And of course, there is a epidemiology association between immune thrombocytopenic purpura and Helicobacter pylori infection. But if we have this, sometimes we can have thrombocytopenia pl- plus anemia. In that case, we have to ask for a Coombs test to rule out autoimmune hemolytic anemia. And this will constitute what we call the Evans syndrome. That is that is very typical to see in SLE patients. Well, the treatment for this pathology will be if we have more than 30,000 platelets per microliter. This is really not high with not high mortal, and just a simple agent like a corticoid can be used. For example, prednisone, like 1 milligram per kilogram per day, or a day for 4 days, and even 4 days course with dexamethasone of 40 milligrams per day. Now we have another pathology related to normal red blood cells, but with thrombocytopenia. In this case, can be due to heparin. When some patients are given with heparin, they can produce thrombocytopenia. This is not severe really, but also this is not associated with bleeding, but rather with thrombosis. It can it can appear after the exposure with heparin around 5 to 14 days, or even after a second exposition to the drug. This is usually due to the formation of antibodies called anti-heparin PS4 that can activate some platelets, and as the platelets are activated, they will start to aggregate, and that's why they will form the thrombi. We have to suspect this in patients receiving heparin, and there is a decrease in at least 50% of the platelets in base of the previous blood count. And some treatments that is related to this heparin-induced thrombocytopenia is argobatam. For example, it has very it's very effective for this. And of course, the the first treatment we have to do to this patient is this to to suspend the administration of heparin. That's why you have to remember the four T's for to diagnose the heparin-induced thrombocytopenia. Like is first, this is at an acute thrombocytopenia, the decrease around at least 50%. The timing of onset, all these criteria will give us 2 points. And thrombosis, this is another T. New thrombosis on an anaphylactoid reaction after heparin bolus. And if we have another cause of thrombocytopenia, that we discard or rule out our heparin-induced thrombocytopenia diagnosis. When we have a score from of 4 to up, so diagnosis is highly sure, and that's why the treatment will be indicated. Now we have some chronic thrombocytopenias, chronic immune thrombocytopenias, like which is related to systemic lupus erythematosus, also associated to HIV, liver cirrhosis, because remember that thrombopoietin is produced or synthesized in the liver. So if there is no thrombopoietin, megakaryocyte will not be stimulated to be formed, and that's why there will not be that release of platelets into the blood vessels or into the bloodstream. Also, sarcoidosis is related to some chronic immune thrombocytopenias. On the other hand, we have the idiopathic thrombocytopenic purpura, also called Werhoff. In this case, we have normal megakaryocytes, but because TPO is usually normal or just slightly decreased, and of course there is some pathological mechanism like premature death inside the spring. About the clinical manifestation, usually there is some bleeding, some cutaneous bleeding, and diagnosis is related to a bleeding time prolonged with anocytosis, with platelet anocytosis. And the treatment will be a focus on prednisone for around 3 weeks for the first two weeks, and then in the third week we will decrease the dosage. If the patient goes to the splenectomy, of course, we have to vaccinate him against some encapsulated bacteria like pneumococcal, for example. Now we have what if I have thrombocytopenia, but plus fragmenting red blood cells. In this case, we are inside another group of pathologies, like is thrombotic thrombocytopenic microangiopathies. This is usually associated or is almost always present the microangiopathic hemolytic anemia because as there are thrombi inside the blood vessels, this will start to cause mechanical stress and therefore they will damage to the cell membrane of this red blood cell. And that's why we're going to see schistocytes on the peripheral blood smear. Also, we have an lactate dehydrogenase elevated and a conjugated bilirubin elevated, but proton time and activated pro- prom- thromboplastin time are usually normal. Okay. In this case, we have two pathologies: thrombotic thrombocytopenic purpura and hemolytic uremic syndrome. In this case, the left one is the of the worst prognosis. It can be inherited, it can be idiopathic, but the main mechanism is that there is a deficiency or or there are some antibodies that attack to Adams 13. This protein usually cleaves the von Willebrand factor, which is a very important clotting factor for coagulation cascade. What happens is that this Adams 13, when it cleaves, so there the protease activity um, of this protein Adams 13 will help to the von Willebrand factor to not accumulate on the endothelial surface, and that's why not producing clotting or thrombi in the blood vessel. But when this Adams 13 is deficient or its activity is diminished by at least 10%, this is diagnosis for thrombocytopenic purpura. So what we're going to see is, of course, it can be related to medication like clopidogrel or some agents that can cause endothelial toxicity like cyclosporine. For this, we have a score that is plasmic score. This usually is based on platelet count, on indicators of hemolysis, no active cancer in the preceding year, no history of solid organ, a mean corpuscular volume less than 90 femtoliters, and iron are less than 1.5 and creatinine less than 2. And the treatment is based mainly on therapeutic plasma exchange with more than 50 milliliters at least per kilogram. Daily antiplatelet count is normal, and also when the signs of hemolysis are resolved for at least 48 hours or 2 days. If not possible, we have to use a some platelet transfusion, and of course, patients with personally low Adam 13 have a greater risk of ongoing sequelae, including stroke. We can use also glucocorticoids in addition to therapeutic plasma exchange, like oraprednisone. And there are some specific treatment, for example, the use of rituximab, just when Adam 13 deficiency is confirmed, or caplacizumab, which will help us to inhibit the interaction between von Willebrand factor and platelets. And the other one is what we call the hemolytic uremic syndrome. This has a better prognostic. This is more common in young people like children after they have an episode of hemorrhagic diarrhea. And this is because this hemorrhagic diarrhea is caused by a toxin called a Shiga toxin, also called verotoxin. This can be caused by E. coli of 157H7 or due to Shigella 2. The main characteristic of this syndrome is that it usually affects more to the kidneys and less to the neurologic system. This also can be secondary to the pregnancy and postpartum stage. In this case, it may require red blood cell transfusion just when there is anemia and hemoglobin is less than 6 grams per deciliter. Also, when platelet transfusion is given when there is active bleeding, also is going to be very important the initiation of therapy with dialysis due to the permanence of the toxin. And we have to test, of course, the acidosis and hyperkalemia. This is due to the acute kidney injury that these patients develop. For hypertension that this can present, we can use nifedipine, and a more specific treatment is based on eculizumab, which is an antibody against C5 that inhibits the activation of complement that is leading to the activation of coagulation cascade. In some manifestations, when we have very low or markedly decreased platelet counts, are petechia, which are um, non-branching areas that can appear in sites of venous pressure, like ankles and also feet, and this usually like these pink points cuffs. We have some here. Petechia is when it's usually a size less than 2 milliliters. Purpura when we have 2 to 1, and ecchymosis when this is more than 1 centimeter. And of course, when it's very low, we can have very low brother counts. We have wet purpura. This is blood filled blisters over the mucosal surface, as we can see in this patient. That is virtually eminent bleeding that is due to the low platelet count. And well, that will be all for today. We have talked about thrombocytopenia. I hope this will help you.